To invite Dr. Subhakar for a talk on pulmonary nodule of the left upper lobe. And Dr. Subhakar So let me introduce Dr. Subhakar. He did his MD and PDCC in interventional pulmonology from SGPGI. Now he is a co-consultant, my co-consultant at KIMS Kondapur. He has 4 years of experience in critical care. And okay. Yeah, so I take over, you can take over from my side.
Thank you, sir. Thank you very much. And thank you, Dr. Vamsi sir and Yugandhar sir, for having me over here. I just was going through your talk, sir. You really had good gut feeling. Unfortunately, I just wanted to share one thing. So where we didn't have that gut at the time when I was doing it at SGPGI, young female of 35 years, she came to us. So it was there was some opacities in the lung, so she was posted for bronchoscopy. Unfortunately, problem in institutes is one person will be seeing in the OPD, the other person will be posted in the scopy suite, and the other person will be there in the ICU. So as a routine, she was taken for the procedure, and endobronchially, they just saw some endobronchial whitish mass. So that was there in the right middle lobe. I was also there with my HOD doing some other work. So as soon as the person who was operating, who took the bite and who came out, along with him came the blood. So immediately there was a code blue and we just rushed it, we intubated her and we have shifted her to the ICU, but we could not revive it. So it was a horrible time convincing a patient, convincing the attenders that who was walking and talking, and a young female of 35 years, around 35 years age. So we had lost her on table. So later we just went ahead and saw it came to invasive aspergillosis. So nice gut feeling, sir. So let me confess, probably I couldn't get a nodule on the left side. So I may be presenting with some consolidation-like thing. So an elderly male, 72 years old, he came with cough from the past 2 months. Initially, it was with expectoration. Gradually, from the past 2 weeks, it was more of dry in nature. He also had shortness of breath, which was gradually progressing from grade 2 to grade 3. He has generalized weakness and fever for the past 2 weeks. He was a current smoker, almost 40 pack years. He was a known case of COPD and was on irregular treatment. As you see, comorbid diabetes was there, and he was treated with piperacillin, tazobactam, cephalosporins, etc. So this was the CT with which he was referred to us. So for this CT, he was attempted, CT get a biopsy outside. Can you get a pointer? It's not here. Okay, so like I think it's just like what the previous image with what Dr. Vamsi sir has that gut feeling over there, the same kind of picture it was seen. So they did a biopsy, but even with the first shot, patient had hemoptysis, so they stopped it and they referred to us for further evaluation. So with this, only these were the things, and he was basically referred for endobronchial biopsy. So fine. Rather than clinical part, I will just be more on the theoretical or practical part of how we do a procedure or how it has to be done. So yes, if you have a bench, if you have a luxury of virtual navigation bronchoscopy, it is very fine. You just need to load your CT, you just need to load the track and just follow what the track shows. What if, or are everyone, does everyone has this luxury of around 1 or 1.5 crores? So if you're not having this, then what can we do? Yes, this is a thing. We have to sit with the radiologist and we have to go through all the tracheobronchial tree. You have to have this spatial orientation. So just for the change, I just kept this. The same thing, literally this was the position or this was the thing which myself, Dr. Avinash sir and Dr. Kiran did in our discussing chamber. So just a small puzzle for you, especially postgraduates. Which figure is a rotation of this object? Can you just say A, B, C or D? Yeah. Any guess? It's a simple thing, just to test our spatial orientation, how it is. I know you're drowsy post-lunch session. I know it's the wrong time to ask these kind of questions. B, yes. You're good to go ahead with bronchial branching and tracing. So this much is enough. If we can just have this much of thing, we can just follow a little bit, we can read and we can just, with time we can be perfect without needing a lung point. So don't get confused. This is the overall picture, how it looks. So I just wanted to say, get yourself oriented with the tracheobronchial tree. So that's it. So first, basics are the basics, then you go one step forward, one step forward. I will just say you, I just kept this picture because, just see this is the right main bronchus, that's the left main bronchus. You see over here, okay, this is the upper lobe, and this is the kind of lingular lobe, and this is the lower lobe. Okay, coming over here, if you see, this is the middle lobe, and this is the upper lobe, and this is the lower lobe. If you see, as we all know that, on the right side, middle lobe will be more anteriorly. Whereas on the left side, the lingular lobe, you see it more laterally. And other important thing you have to know in this whole complicated picture is, you just see this apical one. You see this one B1 and this is B1, okay? So those two apical lobes, if you see the orientation, they go medially. It's arising like this and it just goes like this. Rest of the lobes generally, or rest of the segments, they are like how we see. So then, how do we need to look, or where do we need to look? How do we need to branch? I mean, track these things. The first thing is you should have a proper CT film, and the slice thickness should be less than 1 mm. That's a basic and mandatory thing. Just see the example. Just see the one on the A is around 10 mm slice thickness cut, whereas B and C are 1 mm slice thickness cut. You just see the difference. So if you see in the center, if you see the bronchi, you can trace it. They are fine. But when you go to the periphery with this 10 mm thickness, you can't trace this bronchi. So whatever CT or whenever you're trying to sit in front of your system, you make sure that the slices should be of around less than 1 mm thickness. And then, how do we need to label them? Or yes, we want to study or we want to track it. So some naming should be there, right? So for this, we just classify these generations. Till 6th or 7th generation, we have some labeling available right now. They're not hard and fast anything, but the person who did that first, they labeled in this way. So for reference, we should have something. So we are just following it right now. Maybe in future, these labeling things or etc., they may change. So we don't know regarding that. So even the classification, if you see, the Japanese classification will be different, the US and UK classification will be different. US and UK people, if you see the general thing which we see in our textbooks, right main bronchus will be generation 1, and then they will go for generation 2 and generation 3. Whereas in Japanese classification, if we see, right, upper lobe will be the generation 1 branching, okay? And in this classification, we just need to remember that we have to label it from superior to inferior, posterior to anterior, and lateral to medial. So these are basic things when we are labeling tracheobronchial tree. Okay. So did anyone ever think why we label as B1 the apical segment? Did it strike to anyone? Generally, when we see in the bronchoscope, we just see the anterior segment, posterior segment, and apical segment. Why apical segment is B1? Why not anterior segment B2? So apical will be B1 and B2 will be posterior segment, and anterior will be B3. The reason for this is this thing. When they have named it, they named it like the superior will be the top one, so B1. And if it after superior, posterior, when we are comparing posterior and anterior one, posterior will be the next preference. So that's why posterior is B2, anterior is B3. The same thing in the right middle lobe, lateral and medial. So lateral will be B4 and medial will be B5. This same basic these people have applied even for the further subdivisional branchings. Okay, so after 1, then we have A, B, C, D, E, the next segmental bronchus. Okay, and after that we have Roman letters 1, 2, 3, and 4, and then we have alpha, beta, gamma, and then X, Y, Z, and then some say XX, XY, XZ also. Maybe in future we may get some other terminologies, but generally why we generally tend to look at on 6th generation is with ultra thin scope which is available with us right now, we can negotiate or we can go till 6th or 7th generation bronchi. So how do we need to look at it? First thing, we have to properly study the CT scan. And after CT scan, we have to know where exactly do we need to go. And then we have to have some marking or have this nomenclature, and then we have to go ahead onto the table. So here, just of this complicated thing, just remember only 2 things, right upper lobe and left upper lobe. For knowing better about this, you should have an idea. Whenever we do a bronchoscopy, how do we see? So we will be standing at the head end, behind the head end, so we will be seeing in this view. Whereas the same picture, when you are observing a CT scan in your system, so how do you look at the CT scan? The film which you see in the CT scan will be from the caudal end. That means how you are looking into me. So let's suppose this is some organ over here. I'm a bronchoscopist, so I'll be looking like this. The same thing will be shown in the CT of like how you are seeing. That means that's a mirror image of what exactly is there. So that's a basic thing you should always remember. So that is the only reason, because when we see the right middle lobe, right lower lobe, left middle lobe or lingular whatever, and left lower lobe, we just need to flip the axis in the CT scan. If we flip, suppose this is the thing which we see, we just need to flip like this. When we flip like this, whatever we see over here, that will be a bronchoscopic view. Okay, that's a basic thing. Next thing, for right upper lobe and right lower lobe, what we should do? For right upper lobe, what we have to do is we have to counterclockwise rotate the CT scan by 90 degrees. That is, when we are seeing an axial section like this, we have to rotate a counterclock by 90 degrees. I'm showing reverse to you because for me it is counterclockwise. Okay, can you take the other way around? For the left upper lobe, what we have to do is we have to rotate it by clockwise by 90 degrees. Why we should rotate it? So here is the answer. You see, this is a picture where we can see as a bronchoscopist, when we are trying to trace the right upper lobe, how do we trace it? As I said to you, I stand behind the bronchoscopist and then I rotate my hand. See here, I'm rotating, for me it is clockwise direction. Okay, and then I'll be flexing the lever, then I will point out the right upper lobe. For you, suppose you are the CT cuts. Okay, for you, how it is, when I'm rotating it, it is clockwise direction. For you, it is counterclockwise direction. That is the reason, if we need to study the axial cuts, we have to rotate in the counterclockwise direction by 90 degrees for right upper lobe. The same thing for left upper lobe. What we do when we are doing bronchoscopy, we will be rotating it 90 degrees. For me, it is counterclockwise direction. And for you, it is clockwise direction. So that is why when we're reading a CT scan, for reading left upper lobe or segments of the left upper lobe, we have to rotate it counterclockwise by 90 degrees. So that's the basic for this. I hope I made it clear. And for rest of the things, as I said, you like for rest of this exact right middle lobe, right lower lobe and left lower lobe, we just need to flip it. Okay? So this is the final one. I hope now it is clear for you. So in this Kurimoto's waves, for right upper lobe, we have to rotate counterclockwise by 90 degrees, whereas for left upper lobe, we have to rotate it clockwise by 90 degrees. For all the rest of the lobes, we just need to have a vertical flip for those things. So again, another confusing thing. So yes, we did it, we understood how to rotate and whatever is the thing. Then, how should I say it to my colleague? Or my colleague or my things, where exactly do we need to go? So we should have some labeling or we should have some naming for them. As I said you, how should we name it? So just I'm going to the basics. So see in the picture one, we have the branching of the bronchi will be either vertical on vertical or horizontal. It will be like this. Vertical on vertical means it will be like this. So just imagine a three-dimensional vein. So if suppose the patient is standing like this, if the bronchi is going like this is vertical on vertical. The patient is standing like this, if the bronchi are dividing like this is horizontal by horizontal. Suppose if this bronchi is going like this and some other division is going like this, that is vertical with horizontal. Okay? So whenever we have a horizontal and horizontal division, no matter if it's like this or like this, whenever we see through a bronchoscope, it will be a side-by-side vision for us. So that is why whenever we have horizontal and horizontal division, we always represent as side-by-side, like this. Whenever we are having a vertical and vertical division, suppose it is going like this. One is going up, one is going down. Suppose this bronchi is smaller and this bronchi is larger, or the angulation, whatever it is there, you can just simply put the same thing. If the upper one branching one is smaller and the lower one is larger one, you can put the upper one smaller and lower one is the larger one. Okay? These are the basics of this branching. And just to complicate things further, the one on the left side, yeah. So generally it's a dichotomous branching. Sometimes what happens is it does not branch evenly. We do have many abnormal segments or many abnormal branchings, etc. So even those should be understood and even those should be numbered so that we don't have any difficulty while we are navigating. So with these things, we can name the segmental bronchi 1, 2, 3 and 4, subsegmental A, B, C, again Roman letters 1, 2, 3, and then for subsegmental bronchi alpha, beta, gamma, and then for sixth generation bronchi we can name it as X, Y, Z. So for us, in the case which I have shown you, we at least know that grossly something there is a lesion in the left upper lobe. Okay, so I'll be confining myself to the left upper lobe because I know it's a very complicated topic. Let's make it simple with simple steps. So how does the left upper lobe generally divides? As we all know, apicoposterior segment and anterior segment. Okay, and then it will be lingular segment. Again, it will be superior lingular and inferior lingular. Okay, so this is a general division of the left upper lobe. So as I said, apicoposterior, it goes upwards. So it's in the superior part. So that is 1. 1 plus 2 because it's apicoposterior. And the one in the anterior, it will be 3. So I think everyone can label till that level, 1 plus 2 and 3. Okay, so here we need to, let's go to this. I think, is it clear? Can you see? Okay. Next thing, let's leave apicoposterior. Let's go into anterior segment. Okay. Once we are into anterior segment, then see what all other branches are there. I think rather than this, I'll better show you the video. So this was a mapping which we did it. I'll just show you with the example so you can have a better understanding of this. So this was the CT. I'm just calling it from up, cranial to caudal position in a single go. See, other than this thing, we don't have any other lesion at any place of the lung. Even the mediastinal curve, there was no mediastinal lymphadenopathy or nothing was there. So what I did, it's a left side, so I have rotated it. Okay? And then I just got back over here. And again, I'm tracing it. Yeah, just see over here. See this one, this one, this one. Okay? Okay? If you have seen that picture, just imagine this is your same bronchoscopic view. Can you just say me what can this be and what can these two things be? How we see in a bronchoscope, the one which will be this side will be apicoposterior, and then what is there will be anterior. So with the same thing, as we have flipped it in such a way that whatever we see in the bronchoscope, we are seeing it right now in the CT scan. Okay? So then this will be your apicoposterior, and then this will be the anterior segment. So again we are tracing it. If you see carefully, there is something which is going like this, there is something which is going like this, and there is something which is going like this. So we could see three subsegments over here. Okay? Yeah, I think you see, you could see right? Like this, like this, like this, and something which was like this. That the previous branching was there. So if you observe both the two subsegments, this one as well as this one, both are leading into this lesion, whatever is there, whether it's a consolidation or whatever is the thing. If you go into both the things, we can reach over there. Okay, now I think you can see clearly. Okay? The other one was going anteriorly. So even if you don't know any labeling, or even if you don't understand, sir, what is alpha, beta, which should be labeled or anything, just have this basic thing in your mind. Now just see that the same thing I will just show you in the proper bronchoscopic way. So this is our left main bronchus. And then here we could see the upper lobe, the lingular lobe, and the lower lobe. Okay, then I just put the radial probe. See here. There was one which was going like this, and now there are two things. Okay, the one which was going up was apicoposterior, which we have seen over here. And then again we are having two divisions, right? Let me show it over here. I'll just show it here so that I can control this. Yeah. See here. So we got two divisions, right? 1, 2, 3. And the same thing we just see over here. So again we got, yeah, this is the left upper. So yes, this is upper lobe, the apical. Again we got two divisions over here. Okay? You can see the two divisions. And then I'm going into this one. So again I have two divisions over here. See. This one, we left this and we went ahead in this. After going here, we again saw some two regions in the bronchoscopic view. See, this is one division, this is the other division. Okay? That means we need to go into the one over here. See what we did over here. Two divisions over there. So we went ahead in this lateral one. Again, we could see 2 divisions over here, not the upper, we have to go into the lower one. Okay? So I went ahead in the lower one. Here I'm striving to go and I went ahead. Here again I saw 2 divisions. Okay, let's see what we see in the CT scan again. See this. So we went ahead over here, 2 divisions, we again went there. Again there are 2 divisions over here, see. So in any of the division, if I go, I can reach that. So if I go into any of these two divisions, I can reach the target area. So I'm repeating it again and again so that it will be registered in you, in your minds. Yeah. So we are in left main bronchus. This is the left upper lobe. This is the apical segment. This is the anterior segment. It is again, we got 2 divisions. We have to go in, we need to go into this division. Again here we have 2 divisions. This will go anteriorly and cranially. This is another division. So we went ahead over here. Again there are 2 divisions. No matter how we go, we can reach it. But if you see, the larger one was this. This is the target area which we have reached. The same thing I have confirmed it with the radial image. So I kept my scope over there. I just flushed some amount of water. So I wanted to see whether is it the real target area or just a collapsed segment. So even after flushing the water, I couldn't see any petencil and see the radial one. You see over here. And then from there, we took the biopsy. So is that we didn't have the privilege to have a lung point or anything. Study shows that both lung point and this manual bronchial branching, these are complementary to each other. Nothing is superior to other thing because we have some difficulties or flaws even with this lung point. We see if the proper voxel is not there or if the CD quality is not proper, it will be difficult even for the lung point here. The 3 bifurcations were missed over here. So it depends on the quality of the CT which you acquire. Though for this case, the cytology, sir, it didn't go with your gut. It came to be neutrophil predominant and it has organizing pneumonia with superative inflammation. For this patient, we just treated with antibiotic. We waited. Even after giving antibiotic, he did not subside. Then we started him on steroid. So as soon as we have started him on steroid, the lesion size got subsided drastically. Probably this is secondary organizing pneumonia, secondary to bacterial infection. So he's right now doing good. Only very small fibrotic part is left, and even his immunosuppression is also stopped after 6 months of treatment. So we even evaluated for ANA, etc., to rule out other things, but they all came out to be negative. Thank you.
An excellent talk, Dr. Subhakar. So any questions from the audience?
So I think to avoid suction, we have to use air insufflation. And second one, saline insufflation will artifacts with the radial EBUS. And radial EBUS will have should require a patiency with the team members, more than one treating pulmonologist or dealing pulmonologist. It's unlike linear EBUS.
Yes, sir.
So these are the 3 things I want to add. Excellent talk. For a complex to simple, you made it. Congrats again.
Thank you. Actually, it's not as simple as this. These are only simple part which I have explained it. So I think it will be better for us to go one step at a time. So once we are thorough with this, we can if we have the proper spatial orientation of where is the anterior part, where is the posterior part, which segment is going from which part to medially or which part to dorsally or anteriorly, then we can master in this thing.
Exactly. Thank you very much, Subhakar. This is the very reason I put this session. You you did what I wanted the audience to know, because tracing the CT is not only useful for tracing a nodule, but for any pathology. If you want to trace it where it is, the tracing is very important. I wanted that bronchial branch tracing to be told, not only for a solitary pulmonary nodule, or good that your case there is organizing pneumonia, it's not a cancer, but nodule has become synonymous with cancer nowadays. So the primary aim is that bronchial branch tracing is a technique which exists and which every pulmonologist should be aware of and should at least try to be competent of. They can just do the work on the CT console with the system in front of them, even though they are not going for a radiolibus. We can do that. Whenever I am free, if there is any lesion like this consolidation or a nodule, I'll try to trace it. I'll just keeping it clockwise, anti-clockwise, this, that, flip, and trying to trace it as much as to the possible extent. Sometimes, as you said, the scans won't be so precise and accurate and of the thickness which we expect. But tracing is one thing which we learn, because the very first thing I told to Bhattu sir when I was planning this session is that not everybody has the privilege of lung point or navigation. Nowadays we are all having different kinds of navigation techniques. Now Fusey has come up with an inbuilt navigation in it, the synapse. But the thing is that ultimately, without bronchial branch tracing knowledge, whatever system you are using, without that system, you are nowhere.
Yes, sir.
So if you are not aware with the basic art of tracing, then without the technology we are nowhere. So that's a very good talk. Thank you.
Thank you, sir.
Why it is a clinical vision?
Yes, sir.
Why you are not known for this?
Percutaneous CT can biopsy.
So the first choice was CT gate biopsy. They have to stop the procedure because the patient has hemoptysis on the table. So then they were referred to us. It was attempted outside with the CT gate biopsy. On the first, when they went in, as said by the doctor who was referring and the attenders, so the patient had bleeding on table, but the sample even which they have sent it, whatever they got in the first attempt, that was inconclusive. So this is not a case for radiolibus, sir. Yes, I do agree. But for us, it was like biopsy was attempted and then it was a failed one, so we have to go ahead with this thing.
So in Kidwai Memorial Institute of Oncology, one of the surgical oncology thesis was peripherally located lesions, ultrasound guided biopsies were his thesis. Can we do in this present area also, sir?
So ultrasound guided biopsy?
Yeah, peripherally, such a peripherally located
yes, sir, we can do ultrasound guided biopsy also. This thing, we can access it with ultrasound, sir. Yes, definitely.
Because it is very cost effective.
Yes, sir.
Currently, one of our PGs is doing the same topic. Comparison study with the US Gen CT grad biopsy for peripherally located tumors. We didn't publish the data yet, but we are working on it.
Yes. Even in the chest hospital, we should do n number of ultrasound guided biopsies only. So we.
Ultrasound room is the most sought after room in PG days.
And also, I was wondering, like, why the biopsy was attempted first instance, because like whenever there is some kind of like SPNs, generally we will be using some prognostic tools or indicators like Mayo models or something. Straight away, or else like we could have used some LDCT, keep the patient on follow up. Like I was just wondering, like why all of it. So I don't know what that made. The referring physician maybe.
The first thing they were concerned was like cough, which was not there. Even though he was a COPD patient, on and off inhalers, he was there was issue of weight loss and everything. So I think I just. If I think you're not getting it. Slide. Okay, fine. As the history says, sir, the cough was only 2 months duration with expectation initially, and then it was dry in nature. It was a persistent fever from past 2 weeks. Generalized weakness was there. So all these things were there. If it was a sputum, would have been then they might have sent it for a gene expert or whatever. So is that there was no gene, it was only dry cough as well with the history of 40 pack years of smoking and with the COPD background, they attempted a CT gate biopsy.
feel.
So even we thought, sir, we thought, do we really need to go for a this thing? Because especially when the patient comes post procedure with some hemoptysis or anything, yes, the risk even lies more with which is also. So even if for me going for cryoballoon biopsy was also a bit risky. So we even thought for twice for this case whether do we really need to go. So after examining all those things, and we went ahead with this. Yes, another thing, PET CT would have been better to rule out infection, but unfortunately we don't have that in our center. So it's the general tendency of the physician, ki whatever is available with you, you try to do it. And this was cost effective also, rather than sending him for PET CT again, retrospectively this thing.
And I think even the size of the lesion is also big enough to
Yes.
proceed with the diagnostic modality.
For the youngsters, doing the bronchoscopy is like learning to swim or ride a cycle or a scooter or any other vehicle like a car. When you start reading about swimming in the textbook, looks scary and you will never get into the water. So I think we had a rule in Yashoda Hospital, Secunderabad, when I was running the show, that the young DNB students are supposed to wash the bronchoscope for 10 times, for 10 procedures, then watch 10 bronchoscopies, then assist 10 bronchoscopies, then do 10 bronchoscopies under supervision. So as a result, by the time each DNB passed, each one of them has done something like 200 to 300 bronchoscopies. And the other part is, Dr. Sriram has raised the question of ultrasound guided FNAC. During my early part of my pulmonary practice in the 1980s, I think I have done something like 50 CT guided FNACs for chest, because at that time nobody was ready. So I was ready, so I started doing it and I gained a lot of experience. The one difference between CT guided and ultrasound guided is, ultrasound guided is real time. You can see where the needle is going, where the lesion is, it's real time. Whereas CT guided, you take a cut, you mark on the skin exactly where the needle should be put, and then again you come out of the CT scan room and then watch whether the marker that you have put is at the right place, and then again go back, put the xylocaine, put the needle, push it inside, again you come back. So it is not real time. It has to be multiple times, you have to go in and out, in and out. So that's the problem with the CT guided FNAC. Whereas if it is abutting the pleura, abutting the chest wall, ultrasound is the best.
Yes, sir.
Thank
and
you
sometimes,
so
sir,
much.
even the lateral, whenever for CT guided biopsies, it is placed somewhere over here, the lesion is somewhere here, it will be very difficult while going into gantry, sir.
Yeah,
You have to position the patient. There is an advantage with ultrasound where we can just put the probe and we can go ahead.
Correct. Of course, these days the gantry is much wider, and we can always bring the patient out of the gantry, put the needle, push him again back into the gantry, and things like that. There was stories of Siemens CT scan machine where an obese patient got stuck inside the gantry. And the GE company, which is a rival company, they took the picture of the obese man getting stuck and then said, see, our gantries are much bigger.
Thank you, sir.
Thank you, sir.
Thank you very much. And again,